Good morning, everybody. On behalf of the Division of Allergy and Immunology, welcome to the Stanley F. and Auden K. Hampton Memorial Lecture, named in honor of Stanley Forrest Hampton, who is believed to be the first physician in the country to receive certification as an allergy specialist, and for his first wife, Auden Knight Hampton, who was accomplished in amateur photography and in fencing, and unfortunately suffered an early demise at the age of 50 following a fall. Dr. Hampton completed his undergraduate degree at Washington and Lee University and his medical training at Washington University School of Medicine in 1934. He served in the Army Air Corps in World War II and joined the WUSM faculty in 1940 as an assistant professor of clinical medicine and director of the allergy clinic. There, he took pride in training residents and fellows interested in the field. He went on to assume the role of director of the School of Medicine. He was a founding trustee of the Allergy Foundation of America, the St. Louis chapter of which our division still actively supports, and served as president of the American Academy of Allergy and Immunology in 1955, the latter experience which he shares with today's speaker. Dr. Hampton played an active role in the Medical Services Committee of the American Academy of Allergy, where he helped develop and expand coding and nomenclature and current procedural terminology, or CPT codes, for allergy services in the 1960s. His work was key to standardization of diagnostic and therapeutic terminology. Other areas of his service were prescient of our current health system's focus on value-based care and patient safety and quality. He was chairman of the Academy's Committee on Medical Economics, a group charged with studying the socioeconomic factors which might influence delivery of high-quality medical care in the field of allergy, and discovering means to maintain the value of such care for patients. As a representative of allergy professional societies, he worked with the AMA to develop screening criteria for asthma that was used by hospitals for quality assurance. For all of his exhaustive work in these professional matters, he was given the Distinguished Service Award by the Academy in 1975. And now it is my pleasure to introduce today's speaker, the 2024 Hampton Lecturer, Dr. David Peden, the Harry S. Andrews Distinguished Professor of Pediatrics at the University of North Carolina at Chapel Hill. He also serves as a Senior Associate Dean for Translational Research for the School of Medicine, Chief Research Officer at the UNC Clinical Research Alliance, and Medical Director for the Center for Environmental Medicine, Asthma, and Lung Biology. Dr. Peden received his undergraduate and graduate training at West Virginia University, graduating with a Doctor of Medicine and a Master of Science in Pharmacology and Toxicology in 1984. Following a pediatric residency at West Virginia University Medical Center, he spent 5 years at the NIH in Bethesda, completing his Allergy and Immunology Fellowship training and working as an attending on the consultation service. He started on faculty at UNC in 1992 and has been there since. Dr. Peden is internationally renowned for his research on the impact of environmental agents and pollutants on respiratory and systemic inflammation and physiology. He has served as principal investigator on projects funded for over $70 million by the NIH, including the NIAID, NIEHS, NHLBI, the EPA, and the NSF. He has hundreds of peer-reviewed publications and has delivered scores of regional, national, and international presentations. He has mentored junior faculty, graduate students, and allergy and immunology fellows. Dr. Peden was a co-founder of the Allergy and Immunology Training Program at UNC, having obtained a Phoenix grant from the Quad AI Foundation for this, and I was lucky enough to receive my training there. In addition to his impactful, broad-ranging, and collaborative research, Dr. Peden has served our community in many capacities, as president of the Quad AI, as I mentioned, chair of the American Board of Allergy and Immunology, our certifying body, chair of the ACGME RRC for Allergy and Immunology, and associate editor for JACI. He is currently chair of the FDA Allergenic Products Advisory Committee and editor-in-chief of the Journal of Allergy and Clinical Immunology Global. If all that is not enough, Dr. Peden is also the faculty advisor of the Judo Club at UNC, amongst his many other service roles at the institution. Please welcome Dr. Peden.
Well, good morning. Can everyone hear me? Well, Maya, thank you very much for that remarkably generous introduction. Dr. Jareth was our first graduate out of the UNC Allergy Immunology program, so she was a wonderful prototype and likely remains one of our most august graduates. So today what I hope to introduce you to is a review of the impact of environmental air pollutant effects on respiratory and general health. And I think that while most people are aware that air pollution is bad and that bad things happen when you're exposed to it, the actual health outcomes I'm not sure everyone really appreciates as much as they might. It's actually a really important health outcome problem. This slide is from the Lancet Commission on Pollution and Health, and this looks at worldwide the number of global estimated deaths associated with a variety of different situations, including interpersonal violence, road injuries, AIDS, tuberculosis, and malaria, drug and alcohol use, malnutrition, smoking and secondhand smoking, and then pollution overall. And as I hope you can appreciate, the pollution is the largest impact exposure. When I trained at NIAID, I'm not sure I could have convinced Dr. Fauci that pollution was going to be more important than AIDS or tuberculosis or malaria. But in fact, when you look at the impact on global health, pollution, both water and air pollution, are key drivers of adverse health outcomes. The National Ambient Air Quality Standard for particulate matter 2.5 microns in size is 35 micrograms per cubic meter, and that's just I bring that number up because I'm going to refer to the standard. And an air quality index has been identified, and the red arrow conveniently shows where the standard actually lies. So, when you're when your air quality, when you're at 9 micrograms per cubic meter or less, then that's considered good, and moderate is 9.1 to 35. As an aside, when you're exposed to a wildfire, or if you're in San Francisco, I'll get back to this in a minute, in the 2018 Camp Fire, their particulate matter exposure was about 200 to 300 micrograms per cubic meter for a couple of weeks after the Camp Fire exposure. So that just tells you what levels of pollutants we're talking about. Ozone is probably the most frequently encountered adverse air pollutant that we see. And again, the red arrow shows where the breakdown is. The current ambient air quality standard is 0.07 part per million, so anything below that is either moderate or good. Anything above that is, depending upon how much higher above that, is felt to be unhealthy for at least some people, and when very high for everybody. This is St. Louis. Well, more specifically, this is a graph of the air pollution that St. Louis experienced over the past year. The red line very cleverly shows you where the air quality standard is, just to show you that both for PM 2.5, although that's a little bit more ubiquitous across the year, ozone tends to peak, and the ozone season in the United States runs from April to October. That's when it's mandated to be monitored. Because of climate change, there's serious discussion at the EPA about lengthening the ozone observation period to April through November or December, actually, and that's due to changes in climate and how we're exposed to ozone now. So most of my career has been spent, scientific career has been spent examining and defining human responses to air pollutants. So what's the actual physiologic response to somebody when they're exposed to either particulate matter or ozone or whatever. And with ozone, one thing that happens in a number of people is there's a pain-mediated nociceptive airway restriction. So after people are exposed, you can't take a nice deep breath. It's transient, it's reversible with what's preventable if you take non-steroidal anti-inflammatory agents. It's reversible with opiates. I don't suggest that opiate use is a public health approach to air pollution problems, but that's the mechanism for ozone and its effect on lung function. More importantly, I think, is acute airway inflammation, and that's where it interfaces with a lot of lung diseases, with a variety of other things that happen. Primarily permeability and increased airway reactivity. There's some debate as to whether or not ozone causes systemic effects. The data are increasingly clear that at least in some people there's a systemic inflammatory effect as well. Ozone is made fresh every day, so that's why your ozone levels in the summer are going to peak at 4 to 5 o'clock in the afternoon. It requires, and that's why there are certain days that are going to be worse than others. When you have a heat inversion, exhaust is, combustion products are trapped in the atmosphere. They interact with ultraviolet light. That is what generates ozone every day. So it's days where high pressure front comes through, all the air is blown clean. You're not going to have an ozone day. When you have low pressure area, air is trapped. That's when you're going to have an ozone exceedance. Particulate matter is also a pro-inflammatory, has a lot of effects, including airway reactivity, lung function. Actually, an acute exposure to PM doesn't usually cause the same lung function effect as ozone does. There are a number of cardiovascular effects, and that's one of the things I hope that you'll understand is that it's not just the lung that's affected by bad air. It's a lot of things. These are all sources of combustion. Proximity to heavily traveled roadways, because both automobile exhaust and road dust that's generated by friction, all those result in PM. In many places in the world, indoor cooking and use of biomass fuels is a major contributor to particulate matter indoors. Again, the PM standard in the United States is 35 micrograms per cubic meter. In some homes in the third world where either wood or peat or dung is used as a fuel, the indoor PM levels can be as high as 10,000 micrograms per cubic meter. You could literally cut through the air with a chainsaw, except the chainsaw won't start because there's not enough oxygen in the room to keep the chainsaw going. This is a slide depicting some of the research that we've done. I do this in conjunction with the EPA. We have a specialized human exposure facility on the EPA on the UNC campus that's co-run by the Environmental Protection Agency. We are the country's clinical research center for the effect of air pollution on human physiology. The point I really want to make here is that we demonstrated that at very low levels of ozone, currently lower than the current standard at 0.06 part per million ozone, we still could demonstrate a decrease in lung function and an increase in airway inflammation after exposure to people to this level of ozone. So even though we have current standards, and we could have a whole different discussion about the sausage factory of how the standards are made, how they're promulgated, how they're approved, so very low levels of these pollutants can have this impact. This is a study we just recently published, and here we literally just had people, most ozone exposure studies we use exercise to modulate minute ventilation, which is a dosing thing. That's why you're told not to exercise outdoor on a bad air day because it increases your dose. Here we just had people sitting in the room for a few hours, and even with no exercise at all, there were decreases in lung function and increases in airway inflammation. Much of the inflammatory effect due to ozone is a tissue injury response. In that way, it's an innate immune response, not unlike what might happen with a bacterial infection or a viral injury to the epithelium. Particulate matter, ozone, tobacco smoke, all are associated with increased toll-like receptor and inflammasome component activation and production of damage-associated molecular patterns. And that's the initial mechanism by which much of the inflammation occurs in the airway. In asthma, what we have found, these are data from our lab because it's my talk, but I could show you lots of data from other people's labs that show much the same thing. People with asthma respond differently and more vigorously to air pollution than people without asthma. And in these human challenge studies, the asthmatics we're following that are recruited are very mild. They do not, they're not using inhaled corticosteroids. These are the mild of the mild. They have a positive skin test and they wheeze a little bit occasionally. So those are who we recruit. And what we find is that asthmatics have increased levels of IL-1 beta, decreased levels of IL-10, which is an anti-inflammatory cytokine, and they also more easily make hyaluronic acid, which is which is a result of tissue injury that activates innate immunity. On the right-hand panel, I hope you can appreciate the difference between normal volunteer or NV or allergic asthmatic gene expression profiles. The only point there is that they're different. These are from recovered airway cells after an ozone challenge. And more specifically, some of the genes that are generated and the differences in gene expression generation between allergic asthmatics and normal volunteers. And these are very mild allergic asthmatics. So people with atopy, people with asthma, respond somewhat differently to pollutants than people without. When I first came to UNC, because I was the allergist, I literally was the allergist. My job was to demonstrate whether or not pollutant exposure would enhance one's responsiveness to inhaled allergens. So if one of our first couple of studies was to do a nasal challenge study, and we demonstrated that allergen-induced eosinophilia was enhanced after an ozone challenge. We also found, if you look at the, let's see if I can, does the pointer work? It works here. Well, in any event, in the upper left-hand panel, we demonstrated that the amount of allergen required, or house dust mite allergen required to result in a 20% drop in lung function or an FEV1 is less after ozone challenge. The same is true with particle-bound endotoxin. Endotoxin, it turns out, is a component of PM. It's a significant component in indoor particulates. Water-damaged homes are going to have a lot of airborne endotoxin that you inhale. And we use that as a model. And it turns out that the same thing happens after an endotoxin challenge with people who are already allergic, both in terms of nasal eosinophilia, response to allergen, and response to inhaled allergen. So air pollutants in an allergic person will enhance their response to something they're already allergic to. This is a slide published some time ago, but it represents in Canada the number of respiratory admissions to hospital related to ozone concentration. The ozone concentration is expressed on the x-axis in parts per billion. So this is well below the current U.S. standard. And what I hope you can appreciate is beginning at 20 parts per billion, they see an uptick in respiratory tract admissions to hospital. The current standard is 70 parts per billion, so it's substantially below the current standard. You do see hospitalizations. And in a recent study in North Carolina, we looked at the at associations between particulate matter and ozone with fatal exacerbations among children in North Carolina for asthma. And if you look at the range, look at the levels of PM associated with the fatal outcomes, the higher the PM and the higher the ozone, the significant increase your risk of having a fatal asthma exacerbation associated with those pollutant levels. So this really does cause an immediate acute effect on asthma outcomes. This is a more recent study from the Muppets 2 study, which is a study on mepolizumab in children. It turns out that they had a few different phenotypes for asthma exacerbation. They had those who exacerbated and did not have a viral infection at the time, those who exacerbated with a viral infection, and those children who did not exacerbate during the study. And what I hope you can appreciate, those who exacerbated without a viral infection are shown in the green panels in Figure 2. And their lung function was lower, and the upshot is that the vast majority of non-viral exacerbations in this study were associated with air pollution, and the higher the air quality index, the more likely they were to have decreased lung function and an acute asthma event. So I've talked a bit about how air pollution is associated with exacerbation of disease. It's also been associated with causation of disease. So this is a landmark study that was published in The Lancet. This was published, I think, in 2000, but and basically what they looked at were, they looked at, in Southern California, there are certain areas that have low ozone levels, certain areas that have high ozone levels, and as a surrogate for minute ventilation for exposure, they looked at the number of outdoor sports played by children in those areas, and then they followed these kids for a year, and they looked at the occurrence of asthma in those individuals in the low and high ozone areas. So if you look at children who played greater than 3 outdoor sports, in the low ozone communities, if anything, there was no significant change from the reference, which is kids that played no sports. That was the reference group. And it was pretty equivalent in the low ozone communities. However, if you were exercising in a high ozone community, your likelihood of having newly diagnosed asthma within 5 years of the study was 3.3-fold higher. So again, this was one of the first demonstrations that living in a high ozone area and being exposed was associated with development of, or at least newly recognized disease, if not new disease. This is a somewhat similar study looking at nitrogen dioxide, PM 2.5, PM in a couple of different modes, and coarse mode PM. And what was examined here was the relationship between the time frame between exposure to these pollutants and demonstration of allergic asthma and rhinoconjunctivitis. Here, there was clearly an association, but the association occurred decades later. So the people did not demonstrate their allergic phenotype until they were teenagers, even though their exposures that they looked at were perinatal and early life exposures. So there's something about the exposure to these pollutants that may program you or make you more likely to become allergic, but that occurs 10 years later. So clear demonstration. Exactly how this happens is not entirely clear, but that it does happen is pretty clear, that early life exposure to air pollution results in chronic disease. And this is another slide from a different study that shows much the same thing, that looking at the likelihood of having asthma related to PM or NO2. NO2 is associated with PM exposure. And the take-home point here, again, is that with both of these pollutants, there's an increased likelihood, particularly if you take the average of exposure during the first 3 years of life, of demonstrating both at age 4 and age 11 having asthma. So early life exposure results in later life demonstration of disease. And like many things in healthcare, exposure to air pollution is a health equity issue. This is a study published a couple years ago by Sally Wenzel's group, and they looked at the relationship of asthma outcomes and development of asthma outcomes with various neighborhoods, and they looked at redlined neighborhoods. So redlining occurred in the 1930s, and that was where the ability to buy housing, if you were black and if you didn't have economic resources, the houses you could buy would be in the areas that were relatively undesirable. And here, to paraphrase an old Saturday Night Live, if you had a house down by the river, that was not a good place to live. And that was demonstrated here in the purple zone in Pittsburgh. And these are both complicated slides, but all of these slides more or less tell the same story. They had 4 regions in this red line area that they looked at. Region D was the worst outcome. Area A, Area A was the area where you had the best environmental areas, and that was associated with the best socioeconomic area. And the outcome is that there was more pollutant exposure in the less affluent areas, and there were more asthma outcomes in the less affluent areas. I mean, I could go through each one of these panels individually, but they're here mainly to remind me to tell you that relative to where you live and relative to where the housing location was and the pollutant exposure there, that would markedly increase your likelihood of expressing asthma and having adverse asthma outcomes. So this is a health equity issue. This is a societal policy issue that impacts health in these individuals. So to summarize the impact of air pollution and asthma, the most common pollutants associated with this are ozone and PM 2.5. Pollution is associated with the incidence and occurrence of asthma in children. This can happen years after that early life exposure, and there's an environmental equity issue. Persons of color, persons with decreased economic resources live in more polluted areas, and they get sicker. That comes as no surprise, but it's really, to me at least, it's startling when those data are thrown in front of you and you actually have to acknowledge them. So it's not just your lungs that get hurt by air pollution. There's a significant interest in how air pollution impacts cardiovascular disease. So this map is a map of Northern California. I hope you can appreciate the San Francisco, and the red areas in the middle, in the Central Valley of California, is where there's more air pollution. The Central Valley of California is actually one of the most heavily polluted particulate matter areas in the United States. And that's associated with 2 things. There's a robust chemical industry there. I know that because my dad was a chemical engineer, and we lived in Modesto, California for about 6 years. And surrounding that is a lot of agribusiness. So between the agricultural activities that go on there, and these are really agribusinesses, and the chemical industry, there's a lot of, and the topography of the state, there is a substantial amount of particulate matter in that area of California. And if you look at associated with various areas that have different levels of air pollution, with quartile 1 having a high SES and lower pollutant exposure, and the quartile 4 having lower SES and higher pollutant exposure. If you look at myocardial infarction, or AMI, ischemic heart disease mortality, and cardiovascular disease mortality, the trend here is, if you look at the forest plot on the right-hand side of the slide, all of these things get worse as you live in a poor area and you have more pollution. And this isn't wheezing, this is dying. So this is you have a heart attack, you have ischemic heart disease, or you have some other congestive heart failure or other issue that occurs, and all of that is associated with adverse air outcomes. The percent rate and hospitalization rate related to PM 2.5 is actually fairly robust at a younger age, and then in middle age, which I now call younger age, is somewhat lower, and then above age 75, it begins to creep back up again. And again, just to make the point again, if you look at a variety of measures of SES, which includes overt poverty, household income, population density, and whether or not you had a high school education or less than high school education, poverty and population density was associated with higher risk of myocardial infarction related to PM 2.5 exposure. And the same thing happens with hypertension. So this slide really represents a study looking at the relationship between various pollutants, particulate matter, NO2 and SO2 and ozone, and blood pressure. Long-term effect is most notably seen with PM 2.5, and immediate effects on blood pressure they're increased with the most notable and most sustained is actually PM 2.5 as well. So particulate matter is especially toxic. If I had to get rid of any one pollutant in the United States that's an outdoor air pollutant, I would focus on particulate matter. I'm not sure that Congress has asked me that question, but if and this is a really complicated slide that I'm not going to drag you through, other than to show you that in many ways there are two relative areas that are important. There actually can be CNS inflammation related to air pollution that can impact systemic changes, and then there are areas in the vasculature that are all impacted by pollutant exposure, including fibrin deposition, immune cell activation, and plaque formation. Air pollution also worsened COVID. You all remember this COVID thing? There were some studies, and you're getting this theme right. I'll bet you can predict what I'm going to say with the next slide, which is that if you looked in New York and you looked at areas where there were a number of cases of COVID, and you looked at the PM 2.5 exposure that preceded the COVID exposure, so these are people who have been living in higher polluted areas. So panel A is the location of where the people had COVID. Panel B, and I wonder if I'm not using the pointer, I'm not sure I'm using it correctly, so. Can you see, is there a pointer that's projecting anywhere? No, there's not. Is there? I'm a simple country doctor from West Virginia, so I don't know. Oh, I've come to be rescued. The AV person's coming. Oh, I see. Now the little red dot is on. I'm sorry, I'm 65. I don't do this stuff very well. So these are the areas where people lived, and this is the area preceding COVID where there was a substantial amount of particulate matter exposure. If you look at mortality, ICU admission, intubation, in New York, the people who were at higher risk and the people that lived in the most highly polluted areas were actually Hispanic populations, and they were much more likely to if you look at the relative risk, they had a higher likelihood of dying, they had a higher likelihood of being in the ICU and requiring intubation. And if you look at this with mortality, ICU admission, and intubation overall, the higher the PM that they were exposed to, the more likely they were to have an adverse COVID outcome. But to me, equally important is the fact that it is a very specific strata that represented where these folks lived and what resources they had access to. That was the determinant of how well they did with COVID, or at least one of the determinants. This is another study, from the Kaiser system, and this is looked at the hazard and odds ratios for COVID-related hospitalization and COVID-related mortality within 80 days, related ICU, and the upshot is most notably with PM, but also with NO2, which tracks with PM, the higher the exposure, the higher likelihood you were that you're going to have an adverse COVID outcome. So my summary for this is that air pollution and COVID-19, as with many things, the association of the exposure to PM 2.5 is a pro-inflammatory stimulus. So when you add an acute viral infection on top of that, you're going to have an even more robust effect on these outcomes. So chronic exposure to particulate matter not only causes a long-term chronic disease, but it really enhances the likelihood that you're going to have a bad outcome with an acute exposure. And the most recent one being COVID. You can imagine, the same thing happens with influenza. There's higher risk of invasive pneumococcal disease with exposure to PM. So all these things are worsened with air pollution exposure. So wildfires. Do you have many wildfire issues here in Missouri? Because in North Carolina, it seems that we're on fire about half the time. California, you're on fire all the time. And in fact, if you look at between 1965 and 2015, and these are data, these are relatively old data, the likelihood of acres burned in the United States, and while there's some variation, has markedly increased. And that's a result of a few things. Water use, there's more people live closer to timbered areas, and because more people are there, the demands on water supply are different, and therefore the timbered areas are actually more arid. So you literally have the perfect storm for having increased amounts of wildfire. That's one of the reasons I think you see so much in California, is that you have a large population, many of whom have moved, and that's why the Colorado River is now a trickle, because of so much water demand in Los Angeles, and all of that has impacted the likelihood of experience of wildfire near where you live. The levels of particulate matter associated with wildfire exposure can be stunning. So again, the current standard is 35 micrograms per cubic meter. In the 2013 California rim fire, the exposure was 486 micrograms per cubic per day. And if you look at this in the California counters between August 30th and September 10th of this particular year, you can see areas where the mass intake of PM 2.5 per person could get as high as 18,000 micrograms. So this is a stunning amount of particulate matter that these people are exposed to. So it's really a toxic exposure. In North Carolina, we had an interesting natural experiment where we had a number of counties in the eastern part of the state that have a very similar population demographic, very similar SES issues, and there are parts of the state where there were wildfires, and looking at the affected counties or the exposed counties versus those that were otherwise similar that were considered reference. And in this particular case, there were more respiratory tract visits to the ER in the exposed areas. That's true for asthma, COPD, pneumonia, acute bronchitis. There was also, and heart failure was the one that reached significance in this particular study. The levels of PM in this were nothing like what was demonstrated in the California fires. And if we go back to California, if we look at the daily mean PM 2.5, which is panel A, and you can see the levels are higher, the darker the blue, and the number of days affected by smoke between 2008 and 2016, and you can see the darker the brown is the more PM is being experienced. And that's associated, this superimposes with ER visits for asthma, COPD, other respiratory tract admissions, which are primarily invasive pneumonia, and cardiovascular emergency department visits. So there's clearly an association between this exposure and these events. Wildfire PM 2.5 is also associated with heart attacks and strokes, and this is especially true for people over 65. So you look at high, medium, and heavy levels of PM exposure and the risk of having problems with any cardiovascular event, but it's most notable with heavy exposure in people over 65. So if you're looking for a target group that needs specific counseling about avoiding PM or doing things to minimize their exposure, that would be the target population. So what can you do about this? So far, there have not been any multi-site clinical trials looking at specific interventions that could have been demonstrated to reduce adverse outcomes related to air pollution exposure. Having said that, there are some things that people have examined. One of these, in a population of COPD patients, I take that back. This is children with asthma. I'm going to show you the COPD patients in a minute. This is looking at using a bedroom particulate matter, a high-efficiency particulate accumulator, or a HEPA filter in bedrooms of kids with asthma. And they looked at a variety of respiratory tract outcomes, in terms of outcomes of true filtration versus sham filtration. So this was a placebo-controlled study, and then they looked at this, looking directly at the PM exposure, regardless of what the intervention was, with health outcomes. What I hope you can appreciate is that in the bedroom where there was active filtration, there was a demonstrably lower amount of PM 2.5 in those bedrooms, so that actually will reduce that exposure. The outdoor levels were not changed. You wouldn't expect them to be changed, but the bedroom levels were changed, and the HEPA filters were associated with that. With ozone, there was really no change, and one wouldn't expect a change in ozone because these are particle accumulators, but just as a comparator. The take-home message is that when you compared true filtration with sham filtration, those who had true filtration had better lung function and better oscillometry, and likewise, when you look at their, the effect on their on PM levels with lung function outcomes, that was also improved when you had lower PM levels. This is the study looking at filtration in a cohort of COPD patients, actually looking at a variety of heart rate variability measures. So this is looking at cardiac outcomes. And if you look at those people where, this is the placebo filtration, this is active filtration, and the difference between the groups. What I hope you can appreciate is that with many of the measures for heart rate variability, they were all improved and better in persons who, in the COPD patients that had active filtration in their bedrooms. So you could take these data and you could make a reasonable argument that using a high efficiency particulate accumulator and putting it in the affected person's bedroom should have a positive outcome on their life. That's not giving them more medication. That's not having to treat their disease overtly with pharmacology. This is an engineering maneuver that one can use to decrease their exposure. We've also looked at the impact of corticosteroids given either immediately before or immediately after an experimental exposure to ozone or wood smoke particle exposure. So our hypothesis was if you were a person and you were unavoidably exposed to air pollution, and you were to use either you knew it was going to be a bad air day. So in the left-hand panel, this is a study we published in Environmental Health Perspectives where we looked at either a placebo inhaler or using a single dose of 0.5 milligrams or 2 milligrams of fluticasone. So this is a lot of puffs, but we used this prior to the ozone challenge. And what we found was that there was less inflammation present when pre-treated immediately before exposure with fluticasone. So one could argue that if you're an asthmatic and you know that you're going to be exposed, you might choose to use some prophylactic inhaled corticosteroid as a way to minimize your exposure. Again, I want to be crystal clear about this. This is not an FDA-approved indication for steroids. This is not, this is not a multi-site clinical trial. So I'm fulfilling all the CME requirements of disclosing that this is not an FDA-approved indication. But the data would suggest that it's kind of akin to environmental smart therapy for those of you who are familiar with smart therapy for asthma. You use high-dose corticosteroid when you're going to be exposed, and there's a possibility that you might have lesser amounts of inflammation, and we make the argument that lesser amounts of inflammation is associated with less disease occurrence. We also looked at the difference in sputum neutrophilia after a wood smoke challenge, and here this was actually a DoD project, and their question was: you have war fighters that are suddenly exposed to a bunch of, in a war setting, and they're suddenly exposed to a big cloud of particulate matter. There's something they can do to mitigate that effect, and it has to be cheap and deployable. So this is not going to be a monoclonal antibody infusion. This is not going to be an immunobiological. So we picked prednisone. And we gave people 60 milligrams of prednisone or placebo immediately after a 2-hour exposure to 500 micrograms per cubic meter of particulate matter. And what I hope you can appreciate in those people who are responsive, we find about 70% of our volunteers are responsive in an inflammatory way to this wood smoke challenge. And in responsive individuals, we found that the prednisone did in fact decrease the resultant inflammation that's associated with wood smoke challenge. We also use scintigraphy, which is you inhale radiolabeled particles and look at clearance of particles from the airway to look at mucociliary clearance. We didn't see any effect on mucociliary clearance with the prednisone, and there was actually diminished mucociliary clearance with the PM exposure. But at least with regards to overt inflammation, our argument is that acute corticosteroid might be helpful for those people who have episodic high-level exposure. We've looked at a variety of other things, and for time reasons, I didn't go through all of these. The corticosteroids I wanted to share with you because they're immediately available, they're inexpensive, and they're usable. We've actually studied antioxidant vitamins. I study a vitamin called gamma-tocopherol. That's a variant of vitamin E that's most commonly found in diets. And we find that gamma-tocopherol does in fact decrease mucin production at baseline in asthmatics. We also find that using our endotoxin challenge model as a particulate model, we find that gamma-tocopherol reduces that immediate response. So if you extrapolate this to a more dietary exposure, I could yet again endorse the Mediterranean diet as perhaps a way that you would mitigate adverse outcomes to air pollutant, because you're going to have more of these kind of molecules naturally in nutrition. We've looked at anakinra within the toxin challenge, and so IL-1 beta inhibition also is something we can do. Filtration in rooms, I think, is a much more palatable. I mean, if you can afford the $500 HEPA filter, it actually does seem to have some good outcomes. And there's about 5 or 6 studies now looking at primarily older populations, looking at cardiovascular outcomes, where filtration devices in the rooms did yield better cardiovascular outcomes in terms of blood pressure control and heart rate variability. Masking would make a lot of sense to use. The problem is people don't wear the masks when they're, particularly like we always recommend that firefighters wear N95 filters when they're fighting fires. Well, their minute ventilation is about 17,000 times higher than normal because it's actually really vigorous to be a firefighter, and they just don't wear the mask. But for a casual asthmatic, and the data are evolving with this, but I would also recommend that an N95 filter for an asthmatic who's especially brittle on a especially bad particulate matter day, that would be a reasonable thing to recommend they do if they're going to be outdoors or they're going to be unavoidably exposed. All that said, what makes the most sense are policy interventions, period. All this stuff, I mean, the individual interventions were great for me because they funded my lab. But in terms of actual health outcomes, what really makes a difference is we have cleaner air, and you have cleaner air with policy interventions. So one of the best examples of this that you're ever going to find is when a city has competed so they could lose money hosting an Olympic Games. So one of the criteria that the Olympic Committee asks every city that hosts a Summer Olympic Games is, how do you maintain good air quality? What are you going to do to mitigate this? As you recall, during the Beijing Olympics, they actually very much restricted automobile use during the time of the Olympics, and for about a month preceding that. This also happened in the 1996 Summer Olympic Games in Atlanta. And the reason I show you these relatively old data is because it's one of the best demonstrations of this in the United States. In this study, Atlanta was asked the same question. So they actually really, and if you ask people who lived in Atlanta during the Olympic Games, it was a pain in the butt. They hated it. You couldn't drive through the middle of town. You had restrictions on where you could drive, how often. All kinds of things, primarily to affect the ozone level. Why? Because remember, the ozone has this nociceptive lung function effect. If you run a marathon in a big ozone day, that's like really inconvenient because you can't breathe. So they want to minimize that. So this is the percent of the National Ambient Air Quality Standard that existed in Atlanta prior to the Olympic period, during the Olympic period, and you can see it was reduced, and then when the Olympics were over and everyone went back to their normal way of driving, the ozone went back up again. Less true for the other pollutants, but in this case, ozone was really the target pollutant. And if you look at acute asthma events versus acute non-asthma events from a variety of Georgia medical data sources, so looking at Georgia Medicaid files, looking at the emergency care of hospitalizations, HMOs, you looked at emergency care and urgent care and hospitalizations, pediatric EDs, and the Georgia Hospital Discharge Database. And each one of these things, comparing the baseline period to the Olympic period, there was anywhere from an 11% to a 44% decrease in these health outcomes during the Olympic period. Now, people would think, well, yeah, but everyone was just inside watching the Olympic Games. So they looked at non-asthma events, and I presume that bar fights and trauma and other kinds of reasons to go to the ED, those didn't change at all. So this was very specific with asthma events that were reduced during the cleaner air period, and things went back to the way they were when they relieved those standards. More telling is what's happened in California. So unlike many states, California actually has a very robust clean air law. It's actually in some ways more robust than the federal law. As you may recall, intermittently, depending upon the administration, there are challenges to California, the right that they have to impose stricter standards than the federal standard, and usually California has withstood those challenges. But what I hope you can appreciate, these are a variety of areas in Southern California, looking at nitrogen dioxide, ozone, PM2.5, and PM10. And I think the general trend you can appreciate from 1995 through 2010, for the most part, especially in the higher polluted areas, there is generally, for the NO2 and PM especially, there are marked improvements in air quality that have occurred over those couple of decades. So associated with better air quality standards and associated with driving patterns and other approaches to reduce air pollution, the air pollution is actually reduced. And conveniently, what was also demonstrated is that looking at a variety of measures of lung growth, either FEV1 or FEC, and if you look at the x-axis for both FEV1 and the lower panel FEC, the higher the pollutant level, the lower the lung growth is for each of these measures, for each of the pollutants. And what I hope you can appreciate is that for the most part, but this is especially true for NO2 and for PM, the cleaner the air got, the better the lung growth was over time in those pediatric populations. So this is a really, over time, demonstration that your baseline biology is better if you breathe cleaner air on a regular basis. And that's the result of policy regulatory change. Different publication out of the same study, they also looked at the occurrence of bronchitic symptoms in children in California, looking at the same time frame, and the upshot is that there were notable decreases in acute bronchitis related to improvement in air quality during the same time frame. So the take-home message I would have for you all is that in the 1996 Olympic Games, I didn't show you the North Carolina Clean Smokestacks Act. Where in North Carolina we also had air quality regulation that reduced industrial PM exposure, and that's been associated with reduced asthma, emphysema, and pneumonia events, reduction of pollutants in California. Each one of these things is associated with improved health outcomes. So to summarize all this, pollution is a significant public health crisis. It's as significant as infectious disease, as significant as dietary causes of cardiovascular disease. It is a big deal. Ozone and PM2.5 are the critical air pollutants, and if I could, like I said, if I could get rid of one pollutant or reduce it, it would be PM2.5. Ozone is seasonal, PM is year-round. Both have respiratory effects, but particulate matter has notable cardiovascular outcomes. And PM is also associated with lower respiratory tract infections. There are personal interventions that are evolving, and we've gone over them. And for individual patients who are going to be unavoidably exposed, it's worth considering those. But the most important thing is, as a scientific and medical community, it's incumbent upon us to advocate for better clean air standards. And frankly, the economic impact, I mean, the argument is that the clean air standards are going to be expensive, and they are. But so is dying from a PM-related heart attack. So, I will leave you with that as a medical community, if we can advocate for cleaner air, and hopefully I provided you with a little bit of data that would support that argument, we can do all our patients a lot of good. Thank you very much. It's been a pleasure to have a chance to speak with you today. I'm even kind of on time.
Thank you very much, Dr. Peden, for that wonderful talk. Are there any questions? While we're waiting for somebody, I have one. As you mentioned, PM 2.5 is probably the most significant pollutant worth getting rid of. So what's the most important measure? I mean, obviously having higher air quality standards is good, but what will allow us to get to those standards? Is it electric vehicles, or what will be the most important change?
Well, there are a number of things that could be looked at, and these are both policy and engineering solutions. Most people who look at this seriously believe that electric vehicles and hybrid vehicles, but most importantly, electric vehicles do decrease PM. And the more that we move from gasoline-powered engines to electric engines, the less PM that they will generate. But what's equally important is where you place and the kind of pollutant controls that are placed on industrial sources of PM. So electric power plants need to be, you need to have the right scrubbing devices. Ideally, natural gas is better than coal-powered fire plant. I mean, I'm from West Virginia. We're all about coal. Coal's just poisonous. It really is as a fuel. So those kinds of changes. There's actually, interestingly, there's increased talk about using small-scale nuclear energy now as a way to deal with this. The same level of nuclear reactors that are found in nuclear submarines, actually, not the giant 3 Mile Island thing, because I mean, I lived in West Virginia, so when 3 Mile Island happened, we were kind of worried because we thought that Pennsylvania would melt and drip all over us. But the reality is that small level, so there are a lot of engineering solutions. So I mean, I'm going to sound like a clean air commercial. I mean, there's solar-based power plants. Better insulation, so things you can do to reduce the PM load. Make sure your house is well insulated, because energy use in your home is what drives more the need to generate more electricity. That's going to, whatever fuel source the utilities are using to generate that electricity, the better off the less there is, the less pollution there's going to be. So it's not going to be any one thing. It's going to be a combination of multiple ways. Simple things like public transportation. I mean, I don't use public transportation. I drive my electric car because it's my toy. But public transportation for many people is a way to reduce the amount of PM burned per mile traveled for people. So there are a lot of things in combination that we're going to need to do. But most of that actually, we think about needing to do these things at the federal level. Most of this kind of regulation happens locally and at state levels. And this is where physicians who live in an area, I mean, so I served on the North Carolina Environmental Management Commission for 6 years. The state law required a physician to be there. When you show up as a physician at these public hearings, it actually does make a difference. And as silly as it sounds, wear your white coat or make it very clear, yeah, I'm a doctor, I'm a real doctor, and this was really bad. You should not let this happen. And and oftentimes I've been in hearings where I've been asked to testify about this, and the power company said, well, are you sure? I said, yes, I am. That kind of settles the argument. I mean, they can try, as long as you have the data behind you, especially as physicians and nurses, healthcare professionals pleading with regulators to clean up the air because people are dying of heart attacks. That's the kind of impact that I think we need, because that's what will drive the ultimate regulations that will then encourage. I mean, no one in the power company is evil. They're looking at their cost of doing business. They're looking at how they get things done. But in order to drive it, that's why we don't have Autobahns, because we perceive that really high-moving vehicles are more likely to have wrecks. And the same thing as with power plants. If there's regulations that force them to be cleaner, they will ultimately adhere to that. I feel like I'm preaching. I'm sorry about that.
Yes, Armin.
Thank you very much for this talk. It was just a great summary of all socioeconomic and ecology altogether. I just wonder, as a developed country, United States, and having all these factories, could we see this higher pollution in the underserved areas? What is this? Is it
So if I heard you correctly, I mean, the question, I mean, this gets back to the redlining thing that still permeates the way real estate is valued today, even though you're not officially redlined, and the value of property and what it costs. I mean, the redlining basically made sure that certain groups were going to buy property that was next to power plants, that was next to industry, that was next to polluted areas. You know, I mean, if you know, people with money usually live on the top of the hill with where the air is cleaner and is further away from the river traffic where everything flows. So that's another area where regulatory reform and actually really thinking about what's the impact of these industries on the affected communities. The catch-22 is that oftentimes we counter that argument and you say, but look at all the economic opportunity we're going to bring to these areas. Now, I'm not sure the data really support that those industries being located in those less affluent neighborhoods relates to better outcomes, economic outcomes for the people that live there. But I think this is, these are policy questions that ultimately, force us to live as a society. I'm not sure I answered your question, but I did say things.
Jeremy.
Aside from global warming, how does the developing nations, the pollution that they're producing, does that affect our air quality in any direct or indirect way other than global warming?
So yeah, so there are fugitive air, there's a term called fugitive air pollutants, where the pollutants drift and move away. Now, in developing countries, I would argue that the biggest polluters in the world are China and the United States, period. So if we're looking at, we're talking about air quality, the air quality issues in the developing world are primarily indoor air quality because people use bad fuels or less expensive fuel sources. They literally burn grasses and animal dung and wood, and they burn them inside their house. And there's a big culture component. I mean, it's not just that they can't afford it. That's what they do. But the upshot is that but to directly answer your question, yes, air pollutants can travel. I'm not sure that the Chinese PM makes it all the way to the U.S., but the Chinese PM does get all across Europe, and American PM gets all across North America.
Andy.
So, we talk about PM 2.5 as it's kind of a uniform thing, but it's not, right? Like it's very heterogeneous and varies by season. So, I mean, what are the components of PM 2.5, and are there, at least I think of them as like having a lot of hydrocarbons in them, but are there other organic matter or other things in PM 2.5 that are?
So that's a fair question. So most of the data, it's interesting. When you look at it, most of the epidemiologic impacts seem to be a mass effect of having any mass there. Having said that, there are differences in quality of the PM 2.5. So, for instance, if you have PM 2.5 that comes from fuel sources where certain kinds of coal have a lot of metals in them, so metallic PM 2.5, and you get Fenton chemistry, so you actually have redox reactions that can occur with that. That maybe is more an occupational exposure than a global exposure. Much of PM, though, that comes from burning carbon-based, so wood, most of the burning of carbon-based fuels has a large amount of polyaromatic hydrocarbons and partially combusted carbon-based materials that remain on the coating of the PM. And that's probably the more bioactive materials. It's kind of like, it's almost like tobacco smoke in that same way. But you're right, depending upon where you are, and for instance, in Utah, there was a metal smelter, and there you had very specific bad outcomes that were related to metal-based PM that was there.
So I understand this is a really complex, intervention that that needs to happen for multiple ways. And I saw your slide with the Olympics, and I was just wondering about COVID, what COVID has done for all of this, because it sort of made us think about what air we breathe, environment, and the mask wearing, and probably seeing some of the effects that the Olympics did for the air quality. And I'm just kind of wondering how, now it's also complex because people didn't interact, they didn't get infections and all that. Obviously for asthma exacerbation, we saw a huge dip during that time.
So-
I was wondering, like, you know,
So-
overall, is there an opportunity for us to think about this more, or is it gonna push us more because we've had this period that the air was different, we thought about it more?
So during COVID, the COVID events kind of blew over a lot of the other outcomes you look at. But if you looked at the pollution levels during that time, there's no question in New York, the PM 2.5 went markedly down because a lot of COVID happened during the winter. The ozone was not as affected, but the PM 2.5 in areas where there was, as you would expect, there's less traffic. It was a coronavirus-induced Olympic Games, right? I mean, you know, everyone drove less.
Worse than that.
Well, so, and the relationship between PM and bad COVID outcomes were people who'd lived in highly polluted areas beforehand and they were already primed, and then they got COVID. So yes, COVID clearly demonstrated that if you drove less and stayed inside more and didn't use as much fuel in that way, your air would be cleaner, and that point is well taken. I'm not sure that I would suggest another COVID episode to clean up the air, but that's